Good afternoon. My name is Daniel Piñeiro. I'm from Argentina, so I'm not very fluent in Spanish. And could you imagine in English? So I'm the current president of the World Health Federation, and for me it's a big pleasure to be with you today in this very informal meeting about Chagas, but to be informal is not to be not serious because we are in front of the very, very important disease, not only for Latin America, but today for United States, especially the states in the south, for Europe. Even there are cases in Japan and in Australia. So this is a worldwide problem. Let me ask you just to start. If you know about, if you all know what's Chagas disease, somebody know, who knows about the disease? You know, no. Please put your hands. Who who didn't see one patient with Chagas disease in this group? There are two people. Only two, three, four. So it's good for you to understand what's this disease. This is an infection disease that become a chronic disease. 30% of people that get the infectious will have a cardiac problem. Could be heart failure, or could be arrhythmias, very, very severe. And you have here a very, very high-level specialist panel to ask any question you have. There are not stupid questions. There are stupid answers only. So, so the problem is for them, not for you. You can ask anything. Let me introduce the panel we have. We have Dr. Antonio Ribeiro, who is coordinator of the Teleassistant Network in Minas Gerais and the Telehealth Center of the Hospital das Clínicas of Federal University of Minas Gerais, Belo Horizonte, and chair of the World Health Federation Neglected Cardiovascular Disease Expert Group, and more important, he is my friend. Dr. Raquel Marcus, she is a cardiologist. It's very important to have people based here in the United States with such interest for Chagas disease. Raquel is in MedStar Heart and Vascular Institute and is director of the Echo Lab at the MedStar Union Memorial and MedStar Good Samaritan Hospital in Baltimore. In my right, I have. Okay, I say it's a very nice panel. We have Luis Eduardo Echeverria too, but you know, sorry for that. Luis Eduardo is from the Fundación Cardiovascular de Colombia, and we have a long relationship, and we met many times around the world. So nice to see you. And most important, we have Sateh Sakil, who is a research fellow, Division of Cardiology, Department of Medicine of the University of Washington. Let me say that Sateh was with us in Buenos Aires for the Emerging Leader program last October. And she is making some research in Chagas disease. So this is just the introduction, and I will start with, do you have some questions now? Not now. For the news? No question? You know? Nothing. Okay. So I will start with some questions that Sean Taylor, no, not you, no. Kate, but you are the last responsibility. So, just to start with Tom, Antonio, uh, I will ask you, could you tell us more about the study you are undertaking in collaboration with OHA Federation?
Yes, first, thank you, Daniel, for the invitation and you all for being here. We are trying to study to the burden of Chagas disease, how there are some estimates, and Luis is part of one of these efforts. And we know that now health policy is based a lot in the burden of each condition, each disease. So we have year by year the Institute of Health Metrics and Evaluation from the University of Washington releases the burden of disease study for all countries, all conditions. And we have always seen that Chagas disease appear in a very modest way in this burden of disease study. So we see that the number of deaths seems to be very low, and the burden of disease itself is not very high. And when we go in details in this data, we can see that the burden of disease is related to how many years you lost because you die early, and how much you live with disability, with heart failure, with arrhythmias. And so it's a complex calculation that see how many deaths are being reported due to Chagas disease, and what is the frequency of the prevalence of the disease, and how many are living with serious conditions. And when you go to the data, inside the data, you can see that there are countries in which we have a prevalence of Chagas disease of 1%. In surveys and studies, that you go to the death certificates, you can find 30 deaths related, attributed to Chagas disease. What's happening? What's happening is that Chagas disease is a silent disease. People who have Chagas disease generally do not know they have Chagas disease. People from the capital of these Latin American countries, our countries, or even in the US, see patients with heart failure that are related to Chagas disease, and they do not know that Chagas disease is the cause of the disability. So there is a very strong hypothesis that the burden of Chagas disease is reduced, is diminished, because there is no deaths related to Chagas disease are not being reported, and also because we have very old data on prevalence of Chagas disease. So the study that is sponsored by Novartis Global Health to the World Heart Federation, so it's a partnership between World Heart Federation, Novartis Global Health, and Federal University of Minas Gerais in Brazil, and has a collaboration with the Institute of Health Metrics and Evaluation, has the intention to see what's the real burden of Chagas disease in order to, if it's really underestimated, we have the right numbers, the cost of the disease also associated with this, in order that government from the endemic countries, from non-endemic countries can see what's the importance of recognizing these patients, treating these patients, and give the attention for Chagas disease that is not occurring now. So this is a study that tries to go to the original data from number of deaths, the prevalence of the disease, and to calculate again the burden of disease with these findings.
It's okay, but let me ask you, as a researcher, you have been working in Chagas disease for many years. Which is your feeling about the burden of Chagas disease in our region, let's say in South America? Do you think we will have real numbers now with this study, but just today, what's your feeling about that?
I think that I see a lot of Chagas disease patients myself, many, in outpatient clinic, inside the hospital. In Brazil, they are getting old, So it's not only Chagas disease, you have all the chronic degenerative disease, hypertension, coronary artery disease along with, and they continue to die much more than patients that do not have Chagas disease from the same population. I think that since some time in the past, the Latin American countries are very happy because they were able to eliminate the vectorial transmission of Chagas disease inside houses. And what happens, the disease is still there. When you go, we had some new surveys in some region of Minas Gerais state, it's in the middle of the state, that we can find 10% of the population of one municipality, 12% with Chagas disease. We can find children with Chagas disease positive, with the mothers are not having Chagas disease. So I think that this is still there, it's still silent, and people are not seeing what's happening because consider that the disease is controlled. There are no new cases in many of these places, but people that were infected 20, 30 years ago, they are still there, they are still becoming ill because of Chagas disease.
Just for new people, could you clarify what's the vectorial transmission of the disease in the region?
Yeah, Chagas disease
for
is
the new,
mostly a
I
zoonosis.
know the others.
So there is an insect that sucks the blood from mammals and persons and humans, and when it sucks the blood in the feces of this bug, there is the infecting form that go inside the body of humans and mammals, and there's a cycle that goes from this bug and the human, and this is a disease that occurs because of the ecological imbalance. So what happens that this disease exists in the wild, in the forest, but in Latin America, what happens is that cities and farms invaded the forests, and then these insects came to the houses of persons. There are very poor persons' houses that are not painted. They have very small holes that the insects can stay. And what happened is that there is a very strong activity in Brazil, Uruguay, Argentina, Chile, and some other countries in order to go to each of these houses and to eliminate the vector inside the house. And it was very well done from the 70s to 2005, 2010. And what happens from then is that this vectorial transmission related to this bug has reduced very, very much in this place. What I'm trying to say is that it's reduced, but it's not completely solved. It's still there in some places. And and the second is that people that got infection when they are young, they are still there. So people generally get infected from 5 to 20 years old. Now they have 40, 50, 60 years old, and they still have Chagas disease, and they're still at risk of dying for Chagas disease.
I will jump a little to, sorry ladies, I will jump to Luis Eduardo just to ask him if there are other ways for transmission of Chagas. Not explain that, but just to say which are the other no, you know him. Just to know the other transmission way for the disease.
Yes, it's a very important question. The first one outside of Latin America is a vertical transmission, mother to child, and that is important because there are a lot of people living in the United States, in Europe, with Chagas, and this is the first cause of transmission in Latin America is vectorial cause. But transfusions, blood transfusion is an important cause. And the other one is incredible one, is the oral transmission. It's common in places we don't have Chagas or the normal transmission of Chagas, Amazonas, for example, in Brazil and in Colombia, and in many outbreaks in many places in Colombia, 3 or 2 or more people with Chagas, acute Chagas, always is an oral transmission. and that is very important, the other form of transmission of Chagas disease.
Thank you so much. The other thing I can add is there are many patients without any acute infection. Sorry, there is a question, please. No. Go.
Oh, okay. The question is the oral transmission. What is the way to the oral transmission? It's like a normal food intoxication with many forms. In Brazil, they say that the açaí, this is a fruit, but in general, you can ingest the book. The treatment is incredible, and many hosts in the nature, in the cycle, peridomestic cycle, like opossum. I don't know what is the term in English. In the feces of this animal, they can infect the foods, and you can inherit not only the triatomine of the books, always Trypanosoma cruzi. In normally, that is why it's an outbreak. Many people in acute cases in Brazil, in Venezuela.
It's enough.
Only to say that açaí that you have here that exported, there's no risk. It's the fresh açaí. Only to say, yes,
açaí.
Açaí is very tasteful.
Good declaration.
What happens is that when they collect the fruit, the bug is inside there. So when they prepare, there's highly infective. So we have many persons infected. Also sugarcane.
Okay, just to add, most patients with Chagas disease, we cannot recognize the transmission. The acute vectorial Chagas transmission is not so common in Chagas. So you have a lot of patients without some signs, like the sign of Romagna, this kind of things. We are here in New Orleans. This is United States, no? Yes, I guess this is United States. So I want to go to Rachel, but it's Raquel in Spanish. Just to ask her if you feel doctors in the United States, especially in the southern states, are familiar with this disease for the diagnosis, for the prevention, and for treatment.
So I think that's a great question. Can everybody hear me? How many people in the audience practice medicine in the United States? Oh, great. So that's very heartwarming to me, because my job as the medical director of the Latin American Society of Chagas is to try to raise awareness about Chagas disease in the medical community. And I am demoralized at how little we know as a medical community. And I actually thought I would bring some data to this. I'm sorry I don't have slides, so I'm going to read from my cell phone. 10 years ago, some people at the CDC ran a survey through Medscape to ask a variety of different medical specialties what their awareness was of Chagas disease. And so these were US-based physicians. And 23% of the cardiologists that they surveyed had never heard of Chagas disease. 44% of them were not at all confident of Chagas disease knowledge being up to date. And 34% never considered risk for Chagas disease in patients. So about 10 years after I started to do this work, I thought I would try to do a similar survey. It was a smaller survey, unfortunately, but I did something similar through Medscape. Actually, it was through the ACC, I'm sorry. And 6% of cardiologists said they frequently test patients for Chagas disease. 24% they occasionally test for Chagas disease. And 71% they had never tested a patient for Chagas disease. And similarly, the vast majority of the cardiologists who responded said that they had very little knowledge about what to do with a patient who had Chagas disease. The same thing is really true across a wide variety of medical specialties, including, unfortunately, infectious disease physicians, because as all of you in the audience who went to medical school in the United States know, we were all taught about this as a disease of Latin America and told specifically that we would never see it. So why are you going to look for it? I am heartened that over the course of the past 10 years, we've seen a number of groups come online now doing Chagas disease screening. But we're doing a very poor job, and that's I'm a zealot about it. So if anybody wants to talk about starting a Chagas disease screening program, I am the person to talk to. I will support you in every way that I can.
So there is a question there.
I have a question. With the global warming, do you think that there will be increase in the incidence of Chagas disease in more northern latitudes?
So I think that's a fascinating question. We do have triatamine insect, and as Dr. Pinheiro was alluding to, mostly in the lower half of the United States. The triatamine species we have in the United States right now are not very effective at transmitting the disease, in part because also our infestations are much different than what you might find in a rural village in Minas Gerais. We don't have the same kind of housing that they do there. And so we don't generally have people living with thousands of these bugs in their home and getting bitten repetitively. That being said, with global warming, it is possible that some of the more virulent insects, virulent I mean in terms of more enhanced ability to transmit, might move northward. But there's still a lot of factors that argue against that becoming a very significant issue. What we have to, so there's an estimated 10,000 people in the United States right now who have Chagas disease from autochthonous transmission, meaning transmitted because of the bug. There are an estimated 300,000 immigrants from Latin America who have it. So to me, the disease that we're seeing in people who were born in rural areas in Latin America and then have moved here is a far larger issue that we need to face than people with domestically acquired disease. It happens to be my focus also, but it could be an issue. I can't say it's not.
Go ahead.
Sorry.
Please.
Hello, I am Kumail. I come from the Gulf countries, from Oman. So we see a lot of patients with heart failure and conduction diseases, either heart blocks or, for example, VTs. Honestly, I have never thought of Chagas disease to be one of the disease causing these problems, because we are very far away from Latin America, and actually we have never screened for Chagas disease. So for me, being in the Gulf, what will make me screen a patient for Chagas disease? Is it heart failure, which is very common?
Where did you say you practice?
Oman, which is far in the Gulf country.
Oh, well, I mean, I think the context, and please join in, if the person that you're seeing was neither born nor lived in a Latin American country for an extended period of time, nor do they have a mother who lived in that environment, the chances of Chagas disease are very, very small. So vanishingly rare. So there are other diseases that mimic Chagas disease, for instance, sarcoid cardiomyopathy, which is bizarrely similar. So, and there are other scarifying cardiomyopathies that can cause the same thing. But for me, if I'm looking at a patient who seems like they might have Chagas disease, but they have no exposure whatsoever, I'm going to think really hard about sarcoid.
There are many people from Latin America living in other countries.
Yeah, sure.
If you have a patient, for example, from Latin America, I hear many cases that is rare and many tests and no diagnosis. 5 years after that, he's from Salvador, and someone practice a test that is positive. And that is why if you, for example, it's possible in Oman, I don't know, but you have people from Latin America with a apical aneurysm, for example, or another characteristic like inferolateral fibrosis is possible. It's much possible that you have in front of a patient with Chagas, but you can diagnose that you can think, and you can need to think in this kind of people that is possible Chagas disease.
So I just add, if you might.
Yeah.
So we just recently completed a seroprevalence study in the hospital where I work in Washington. It's Washington Hospital Center in Washington, D.C., of Latin American immigrants who were hospitalized and then had an echocardiogram ordered for a variety of indications, most of which could be suggestive of Chagas disease. And in immigrants who had ejection fractions less than 50%, 28% of them had Chagas disease as their diagnosis. But we're very specific to look at Latin American immigrants from Chagas endemic countries. Okay. So I would say if you are seeing Latin American immigrants and you're seeing that kind of pathology, you are seeing Chagas disease.
I have a question for Tom at this point. You have a very nice study of AKG in, let's say, just for this guy from Oman. Hey, my brother. Brother, it's for you. So, if you have a patient, let's say, from rural area of Argentina, if you have some special EKG that makes you think about Chagas disease.
Yeah, so there are some abnormalities that are typical. So there are conduction abnormalities. The most important is high bundle branch block associated with left anterior AMI block. So it's very, very common. It's 10 times more common in Chagas cardiomyopathy than in other conditions. So if you go to a Latin American country or see Latin American patients, this is not pathognomonic because you have other conditions that can give you this condition. The association of this conduction disturbance that can lead to AV block, second degree, MOBT2, complete AV block, but also with tachyarrhythmias, so polymorphic ectopic beats, runs of VT, sustained VT. So there is a trend of having these findings in combination. So you have more ECG findings in the Chagas cardiomyopathy patients than cardiomyopathy from other etiologies. And the combination with atrial fibrillation or these ventricular arrhythmias with the conduction disturbance.
I have an anecdote about that. I have a very, very close friend of mine who is director of one of biggest hospital in New York. And he presented in Buenos Aires a lady from Ecuador and showed the EKG and say, it's okay with right bundle block and left hemi block. So, and he was pushing me and say, I want to know what's the opinion of Dr. Piñero. And he said, it's a Chagas disease. And he said me, I make resonance, tomography, many things, but I cannot think about Chagas disease. So, if you have a patient from Latin America with this kind of conduction problems, think about Chagas disease. Thank you so much. There is a question there.
Thank you. I have been working with Chagas disease for some time. I work in Mexico. And I would say that right now Chagas disease is no longer a disease of the poor. I would say that this is a disease of the migration. So right now, for instance, if you have a patient with fever, with cough, right now you would think about COVID. Well, I would say it's more or less the same with Chagas disease. So if you have the suspicious because he comes from an endemic country, or for instance, he or she has a mother that she's coming from Latin America or from certain endemic country, you should think about Chagas disease. So we are trying to increase awareness in Mexican cardiologists because we also have seen what Dr. Rachel, so Dr. Rachel has just said, that we have no really awareness between or among cardiologists about Chagas disease.
Thank you so much. Thank you so much.
How about tourists? Tourists going to South America for 2 or 3 weeks or something like that?
It's so difficult because vectorial transmission is not easy to do. You need to stay many long time with the vector, and it's not the bite. is the feces, and it's accidental, and you have to stay a long time inside the medium with the box for the transmission. And an accidental contact with the vector with a vector is not is normally is not normally not lead to the infection.
Yeah.
Oral is possible. Oral is possible, but oral is so yes, it's not many cases in the world.
Yeah, it's very uncommon. It's a few hundred cases per year in all Latin America. So the problem is people who live inside the house that infected in endemic region, not to visit.
Question.
Yes, hello. My name is Roland de Jong. I'm from the Netherlands, so a non-endemic country. So I've heard bundle branch block, heart failure, but what are the triggers? You know, it's a rare disease in my country, so I would be looked down upon if I just test for Chagas, you know, in every heart failure patient. So what should trigger me, except the bundle branch block? What clinical manifestation should trigger me to test for Chagas?
So I guess one of the things that I think is really important to say is, while what Dr. Ribeiro said is 100% true, that right bundle branch block and left anterior fascicular block is the classic finding for Chagas disease. If you look in heart failure populations, 10% of them will have left bundle branch block, and there will be some who have ST segment abnormalities, and that's it. So I am very reluctant I've had people come up to me after talks and say, my patient doesn't have Chagas disease, they don't have bifascicular block. It's just not the case. So if you have a Latin American immigrant to the Netherlands who has a significant heart problem, they have a wall motion abnormality you can't explain, they have an apical aneurysm, they're having ventricular tachyarrhythmias, or they're having heart failure, no one should look down on you for testing for Chagas disease. It is the diagnosis. I mean, it's extremely likely to be the case, and it really matters, because if that patient needs to be managed differently, and if they're lucky enough to get a transplant, you have to monitor them for reactivation. If they're a woman, you need to test all of their children. So it's a diagnosis that is very important to make. So I would applaud you for thinking about
sure.
it.
Thank you. But then maybe some signs in blood work or anything else that's.
Well, the diagnosis is made with serologic testing.
Yeah.
So you would order a Trypanosoma cruzi IgG assay. Usually it's going to be an ELISA, although I don't know what they would do in the Netherlands. And then if they test positive, you have to get confirmatory testing, because you can't make the diagnosis with one test alone.
All right. Thank you.
In a chronic cases, in acute cases, you need to see the parasite. It's a different thing. But in a chronic, two serologies positive is the diagnosis.
I will ask you to cut for a moment questions. Sorry. sorry. And just to move to the youngest. First of all, I want to know about your experience in Buenos Aires, not about Chagas. What's your experience in Buenos Aires about the Emerging Leader program? Just to have the advertiser of the Emerging Leader program, because I see a lot of young people here that could be interested in our program of Emerging Leaders. What's your feeling about that in 20 minutes? In 20 seconds.
20 minutes I can do.
Seconds. Sorry. Second.
Okay, so this is a serious plug for the World Heart Federation's Emerging Leaders Program. So I am a cardiologist by training, and my interest is in the intersection of infectious and cardiovascular diseases, such as Chagas, but also rheumatic heart disease, HIV, tuberculosis. And it's a great group of not just cardiologists, but patient advocates, interdisciplinary colleagues. I learned a lot, and one of the things that was most valuable is that I learned a lot about Chagas disease, which is, as a practitioner in the United States, I don't, and especially in Seattle, I don't get to see too much of, admittedly. So we worked on a project to improve detection and linkage of Chagas disease care in Argentina, and that was a really valuable experience, and I just want to acknowledge the colleagues of mine, teammates, other emerging leaders who are not here today, but they were very pivotal in setting up that project.
Let me say that the Emerging Leader program has now around 10 years of development. We choose different topics. The topic this year, last year in October was about infection disease and cardiovascular disease, influenza, Chagas, rheumatic heart disease, and COVID, obviously. So the next one will be in Australia about digital health. So still it's open the possibility for you to apply for this program that is very, very nice. And what's important is that the program started with some educational activities, but the most important thing is the initiative about research on the topic that, and so I will ask Sari about her initiative about research in Chagas disease.
Yeah, very excited to talk about that. So we spent, in a cohort with my teammates, we spent a week putting together a proposal for an implementation science and also epidemiologic survey of Chagas disease, and it's called the In Chagas project, integrated care for Chagas disease and detection and linkage to care in endemic communities in Argentina. And so I think we've alluded to some of the problems with management of patients with Chagas cardiomyopathy here. And the problems that we are focusing on are the fact that this is actually an infectious disease with a non-communicable complication many, many years later with a really long silent phase. And I think that requires a very specific approach.
Sorry for the interruption. It's like rheumatic heart disease, infection disease that then become a chronic disease. Continue, please.
Exactly, which is why I think it requires a unique approach. So some of the goals of our project were to integrate different levels of care. We chose a community in Argentina, Santiago del Estero, and in that community, we are going to design an intervention tailored to the primary care clinics to increase education among the primary care providers about how to screen for, who to screen for, what is the management of Chagas disease, so an educational component about both diagnosis and management. In addition, there's another telemedicine component in which we are implementing handheld echocardiography, so many of you may be familiar with the butterfly devices, so point of care, single view, cardiac ultrasound, as well as EKG screening. And it is both a case detection endeavor as well as an implementation endeavor to see if we can actually train non-cardiology providers to do that first step in screening patients who are at risk for Chagas disease. And the integration of the care is that those diagnostic studies are then sent remotely via telemedicine to a cardiologist at a referral center. So that kind of expedites patients getting into specialty care and then getting guideline-directed medical therapy for heart failure, should they have heart failure. That's kind of the summary of our project.
Thank you so much. So we can continue with the question and comments, because
Yes.
I think from Brazil it's not a question, it's a comment.
Glaucia from Brazil, and I have a question to Tom.
Ah,
Because I think that the most important things for Chagas disease is not the screening, only the screening or the burden of the disease. Most of the treatments that you use to Chagas disease, there is no evidence-based medicine-based treatment. You try to treat like you treat other heart disease. We are launching this month our Brazilian guidelines of Chagas disease, and there is a few evidence-based treatment. So I want Tom to comment about it.
So
Thank you.
about treatment, only trying to summarize, there are two big groups of situations. First is the specific treatment against the parasite. So there are only two drugs available, old drugs from the 60s, benzonidazole and nifurtimox. More experience with benzonidazole, and there is a large clinical trial in those with advanced cardiac disease showing that there is no role in advanced cardiac disease. And there is a set of evidence that are of low quality. There are observational studies, but it's very consistent that if you use benzodiazole in the young age, mostly until 50 years old, in the absence of heart failure or advanced cardiac disease, and there's a very large gray zone here, what's the absence of cardiac disease, you can hasten, you can prevent the progression of the disease. I did not believe this 15 years ago. It was something that we ran several projects. I have to see with my eyes in a way that it's really, I got court studies that people have been treated. They had less complications, less heart blocks, less heart failure, lower levels of BNP, they died less frequently. So there is a lot of evidence, but it's not a randomized clinical trial showing this. We decided to believe that this is the best evidence, that we will not have time to wait for another 10 years for a new study for treating patients. So now the condition is to know what is the best dose. We use 2 months of benzodiazole. It's too much. People have a lot of collateral effects. Maybe using lower doses or shorter treatments are interesting. And to wait for the industry, for the pipeline, there are new drugs to be tested to see if there is a new one. I need 1 second more. Yeah, okay. Yeah, we are friends. There is the treatment of the cardiac conditions, that is heart failure, mostly adaptation of the guidelines from heart failure to Chagas disease. There are new evidence coming from Luis and the international group with sacubitril valsartan being tested in Chagas disease. But in general, you can use beta blockers, ACE inhibitors, the standard treatment in Chagas disease. And the treatment of arrhythmias, that it's also an adaptation of the current guidelines for other conditions. I would like to say only a brief word about stroke. Stroke in Chagas disease patients is a very important issue. It's a cause of stroke in young persons, and Chagas disease increases this risk 3-4 times of stroke when considered. Stroke can be a late complication because you have intraventricular thrombus, but can be also an early finding in some patients.
Just a question to complete the idea about the drugs. These drugs have side effect or not?
Unfortunately, a lot of side effects. I'm part of a group that was trying to understand if you reduce the dosage or the duration, if you can reduce, but 70% of adults can have some kind of side effects, but serious side effects are rare. So side effects that lead to discontinuation of the drug, I do not know your experience, but 6-10% of cases you cannot continue treating, but side effects are common, dermatological, neurological, mostly.
That's very important. You, I know you.
Hi. Daniel is my close friend. I'm Carlos Rapalo from Buenos Aires, Argentina. Rachel, which is your favorite or appropriate test screening about this population?
Well, in the United States, we're
in Washington,
yeah,
please.
We're constrained.
In your hospital.
But I don't have a choice in the hospital. When I'm doing community screening, one of my hats in my nonprofit is to screen in the community. So I'm not a cardiologist there. I'm just doing primary care. I'm very fortunate to have donated kits from InBios. They have a rapid test, and so I use that. And then my hospital sends to a lab that uses the hemogen ELISA, which unfortunately has quite a bit of false positives. Quest, which is the other main lab in the country that does testing, uses the Wiener from Argentina, which we think has better test characteristics.
And the other. And in the same answer in Colombia, the same question, sorry.
It's the same thing. You need at least 2 tests, not only one. You need Lisa and other one, yes, two different. Well, two different Lisa, two different techniques. And in my agglutination, I don't know what is the norm. And is if you have two tests, you have the diagnosis. But in many cases, you have to only one test and epidemiological information, and you see the apical aneurysm or the arrhythms disturbance classic from Chagas, you have the diagnosis.
So just to follow up on what Luis was saying, all of the patients that we identify in the United States generally get confirmatory testing that's free from the Centers for Disease Control, and they run the Wiener assay and then a Western blot, and then they have an IFA if there's discordant serology. So we're fortunate to have access to that because it is free testing. The initial test is generally very expensive, unfortunately.
Thank you very much.
There are another question here.
Hello, I'm Carlos, originally from Honduras, right now training in New Haven. And my question is, so when do you start thinking about screening patients who had a risk factor or exposition coming from an endemic region, right? That's the first question, especially if for instance, you have a patient with cardiovascular risk factors, but asymptomatic with preserved ejection fraction. Second is going back to Honduras. Do we start screening all the patients? I guess patients with significant risk factors with depressed ejection fraction or arrhythmias, we can start thinking about that. But what about the other population in Honduras? And third, is there any guideline that provides a recommendation regarding of transplantation, but in the donor patients? Do we routinely screen Chagas for patients who are donors?
So I'll answer the last question. In the United States, every regional UNOS network has a different policy for what they do about screening. Most of them, fortunately, are aware that Chagas disease should be screened for in any person who has lived in Latin America for an extended period of time. Unfortunately, there are some networks that don't, and so you may actually be aware of the case where someone was diagnosed with fulminant trypanosomiasis, acute trypanosomiasis, after having been transplanted in New Jersey, I think it was. I'm not sure if that UNOS network has changed their policies, but that's an example of how the regional approach doesn't work all that well, and there is certainly a recommendation that all of those individuals be screened. To skip back to your first question, I'm a zealot. I screen everyone. So I would say if you have a Latin American immigrant from a Chagas endemic country, it doesn't matter what they have on their EKG or their echo. They should know if they have Chagas disease. And then I don't know.
100% in Colombia, 100% of the donors are tested for Chagas. It's mandatory. And the other one, people from heart failure in my center, but in Colombia, it's mandatory to make a Chagas disease. It's more common than hypothyroidism or another cause in Latin American countries. That is, you always have to make the screen and change the natural history of the disease. More arrhythmias early with preserved ejection fraction in Chagas have sudden death. It's a different thing.
So just going back to the first question, should I get tested? You know,
no. You are.
I'm from Honduras. I go back there like every yearly.
So the main thing is that if you grown up in a large city, your chance is very, very low. So you have to come from an endemic rural area to be at risk. You can see, now they found someone that was infected in São Paulo near the Tietê River. Yes, it's true, but it's one case in 1 million. What happens is that people that live in rural areas should be tested. There are some questions that the Brazilian health minister has standardized and will be tested recently. So if you have a relative with Chagas disease, it's a very important question. Mother, sister, brother, someone in your family that has Chagas disease. The second, if you have seen in your house the bug, barbeiro, vicunha, what's the name in Spanish? It's
trypanosoma.
No. The bug, the insect.
Kissing bug?
Yeah, the kissing bug.
Yeah.
Tinge. Yeah. If you have seen these in your house when you're young, and the most strong if you have been reported to be bitten, who have stung by this. So these three questions are simple, and if you are from an endemic area, do not have an ECG, abnormal ECG, you can ask them, they can help you to decide. But if you are in a cardiology clinic, someone happens to come from a Latin American region, probably the best strategy is to test everyone. But for us who live in an endemic state, I have to use these other features.
Thank you.
Yeah, so just to tag team on what Tom was saying, I think the issue in the United States is just that we have such poor awareness, and you know what it's like to practice here. So if you make it complicated, people will not do it. So for me, if I go and I try to explain why people should be screening and I start to talk about regions in El Salvador that might be at higher risk, people are like, I can't do it. So you either say, and Shiva Maymandi, who's really responsible for starting the process of screening in the United States, she's a cardiologist in LA County, totally agrees. You have to make it simple. So in the US, we just say screen, and because otherwise people won't do it. It'll just be too complicated for them.
There is another question.
So, hi, I'm Salvador Hernandez. I'm one of the cardiology fellows in Kaiser San Francisco. Hi, Rachel.
Hey.
Talking about Shiva, I came from the Shiva Mimandi's lab. And so I have worked with Chagas also for a long time. And I mean, before you were asking these questions, I was going to just say that our experience has been that we should test everybody, especially here in the US. You cannot make it, as you were saying, Rachel, you cannot make it impossible for people to be like, from what region in El Salvador are you from? Let me bring him up. No, you need to start testing anybody who is from Latin America and then test them. If they're positive, then they're positive and you treat them. Kaiser San Francisco is, we're launching an effort now to test all our Hispanic community in the next couple of weeks. Just because I found that they were interested in testing for Chagas disease, and we are launching an effort for that. But it is incredible that you go to different places and you have to start again, to start teaching again about Chagas disease. And if it's not for Shiba and for Rachel, in the US, people wouldn't be doing it. So for you guys who are in like, for example, teaching hospitals and everything, just involve your primary care physicians. They'll be happy to do so. But everybody needs to be tested. We cannot just be like putting tiers and everything like that. I respectfully disagree, but in the US, we should test everybody.
There are three questions from Oman. You, no, not more, because we are very short questions, very short answers.
Oh, thank you. My name.
It's enough.
My name is Bernardo Lombo. I am originally from Colombia, but I train in the United States and I work at Yale University. We have a cardiovascular global health initiative. We work with our partners in Córdoba, Argentina, Hospital Privado, and we're doing prevalence of the disease in the northern part of Argentina. Now, it's great for us to try to join forces, but where are the best resources here in the US? I mean, we saw what we did with COVID in 3 years with appropriate support. I mean, even in my university, 3 months after the pandemic, we were able to identify the virus in the saliva. We were able to diagnose it, treat it, and now we have vaccines, treatments. It's not the same situation in Chagas. So where are the best resources for young fellows or people who want to investigate in Chagas to apply for grants? Or, I mean, you mentioned that Novartis is interested, and is there any other like big resources where we can find like support or like grants, especially if you want to create awareness in our basic research scientists in our universities here in the US?
Yeah, it's possible to join forces. Right now, we are working with Johns Hopkins in grants to study many things about Chagas, the biological behavior, and many other things, metabolomic, and all the omics. And that is possible. The joint forces, we have the patient, you have the money, and we are going to make many things. We are working together. We are Tom is applied to NIH fund in United States from Brazil, and he have big.
This is a short answer.
Huh?
This is
this is a short answer. No, that is enough. But really, we have to join forces in the people that have the money and the interest, and the people that have the patience.
Dr. Mendoza.
DNDI. It's also
DNDI.
another organization
Yes,
who is really keen in teaching about Chagas disease.
World Heart Federation have money.
There was another question. You, yeah. My friend from Oman. No, thank you.
When you talk about Chagas, you talk about conduction defects and heart failure. Have you seen primary mitral regurgitation because of fibrosis in the papillary muscles and things like that, or it's just heart failure and conduction disease?
Well, we had a great case that we identified through our screening project in the hospital, who was a man who actually had a mitral clip placed for mitral regurgitation that looked like it was ischemic. He had inferolateral scar, and so he had exactly what you're describing, and no one had thought to test him for Chagas disease, which is, of course, what he had. He did not have coronary artery disease. So absolutely, it's a classic finding, actually, because of the predilection for basal inferolateral scar. You're going to see sequelae that look as if somebody's had an MI, but if you investigate for coronary disease, you won't find it.
It's totally different than the other cardiomyopathies. It's for fibrosis and inferolateral wall in the basal and inferolateral wall and tethering of the posterior papillary muscle.
So, last question, please.
Yes, thank you. If we start screening a lot of people, eventually we'll have more patients. But if we start also testing people with risk factors, but not any manifestation or complication from the disease, not everybody who got infected by the parasite will develop heart failure or any complication. So how we will know who to treat in those screening processes? And all the other question is, what about heart transplantation for these patients? Is there any way to prevent it? The parasite gets again to the transplanted heart.
Raquel and I will, all patients with non-advanced disease with less than 50 years old should be treated with benzonidazole that is available in the US. Raquel will tell. So it's very important. It's more important to find those with early disease than those with advanced, because the advanced, by the end, they will receive care for the cardiac conditions. So the other one we can avoid. And something very important, the disease continues to progress from indeterminate to cardiac form the whole lifespan of the person. We have now data from elderly in Brazil, 70 years old, they continues to evolve to heart disease, even 60 years after being infected. So it's very important to recognize them. It's a disease that continues to progress in the whole lifespan. Test and try to find them.
So, time is, we have 5 minutes more. My boss, Sean, give me 5 minutes. Thank you, Sean. So, I want to ask each of the panelists to give one important message for all of you, and I'll give you the last message. Please, Eduardo, first.
Chagas is a unique and fascinating disease. It's totally different than the older form of compromise of myocardium, and we need a new guidelines about Chagas because it's different. More strokes, more arrhythms, more shock if you have a high CD. And you need two diagnoses because the behavior is totally different.
So as a representative from essentially a non-endemic country, I would just say for those of us working in non-endemic environments where we see immigrants from Chagas endemic regions, we really should be testing way more often than we are, because collectively we are missing this disease, and it really matters for precisely the reasons that Dr. Echeverria was saying.
I think my message would be in terms of identifying cases that are late-stage manifestations. In endemic areas, what I've learned from my colleagues is that it really does require an integrated approach to care, thinking about taking lessons from both infectious disease and chronic disease management at the community level. And I would say that we can learn lessons from analogous diseases like rheumatic heart disease, and maybe that's a good place to start with a framework.
And that research is needed in Chagas disease. So what the World Heart Federation is doing is very important to raise the awareness about Chagas disease, the interest in Chagas disease, because there are very, very few research groups working with Chagas disease, and there are so many open questions. and there is a lot of benefit. As you said, for COVID, we solved it in 1 year and a half. In Chagas disease, we are now 100 years without a solution for the disease.
Thank you, Tom. I said that Chagas is very near rheumatic heart disease. It's an infection disease that becomes chronic disease. You know, we know all about rheumatic disease, rheumatic heart disease. So to see one patient with mitral stenosis is a shame for us as physicians, as communities. The case of Chagas is completely different. We need to improve our diagnosis. We need to improve our treatment. We have drugs that Tom told us are, when I was a student, and I'm very old now, so they teach me the same drugs. So, as you said, we need research. We need to increase the money for research and foresee these patients. As you said, and very important your comment, we fix COVID disease in only 3 years. We have Chagas disease since Carlos Chagas from Brazil described the disease more than a century ago. So join us next 14 April. That will be the day for Chagas disease. We will have some activities about Chagas disease, but you can replicate in each place some activities related with Chagas disease. We have to put Chagas disease in the agenda of policymakers. So thank you so much for your participation and especially for the question. This was an amazing roundtable, and I want to thank these panelists that, except Eduardo. No, Eduardo.